Good morning, everyone. Just a reminder that we will be getting started right at 10 a.m. Thank you. Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel throughout today's presentation. If you continue to experience poor computer audio through your computer, try rejoining the webinar using the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recordings and materials used in today's presentation will be available on FADAA's website within 30 business days. To access the recording and PowerPoint, go to www.fadaa.org, then to our Resource Center, and then to our training library. FADAA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADAA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADAA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes. Completing the evaluation is necessary to receive CE credit or to access your statement of credit. Please note the evaluation will close midnight Tuesday, July 26th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. And now I'd like to introduce our presenter, PJ Brooks. He's the Chief Operating Officer for Community Assisted and Supported Living in Southwest Florida. He oversees operations for over 100 properties and 700 plus beds for individuals with disabilities. He is an accomplished behavioral health executive and strategist with over 33 years of providing leadership and program development for people in need of intervention across a broad continuum of care and multiple environments. He is highly respected subject matter expert in behavioral health from prevention to permanent supportive housing. PJ's experience in organizational transformation and consolidation. He is also a behavioral health instructor for varied audiences, including medical practitioners, law enforcement, child welfare, and public, and an advocate for behavioral health. And now I'd like to welcome PJ Brooks. I'm going to pass the presentation over to you.
Thank you. Welcome, everybody. I'm honored that you all have decided to participate in this training. If you see me looking to this direction, it's because I'm looking at notes on a separate screen, so I do apologize. But I think the slides will be what will to focus your attention on. So, all right. Now, here is again the obligatory disclosure statement. I will let you read it. I am not going to read it for you. And I will give you just a second here. And Rebecca, please feel free to at any time jump in to cajole, coach, or whatever you want me to do as this moves forward, so feel free. All right. Today's learning objectives. Hopefully, when you're done, you will gain an increased understanding of the housing first approach. I will be going over that in multiple variations. Heighten your awareness of how lack of stable permanent supportive housing interferes with behavioral health and medical health goals. Develop a detailed understanding of all facets of permanent supportive housing. Also learn about tax credit applications to increase permanent supportive housing units in your community. So, let's see. All right, so now, one of the things that we first need to do is, in my opinion, is identify the target population that we're trying to serve with permanent supportive housing. And some of the aspects and profiles that we see with the individuals that come to us seeking permanent supportive housing are that they present with a disabling mental health condition. From our perspective, from CASEL's perspective, when we are in numerous counties across the state, consistently what we find is the diagnoses, the 3 primary diagnoses that we experience are schizophrenia, severe bipolar disorder, and post-traumatic stress disorder. Seems to be a theme for many of the individuals that come to us. In addition to that, we also experience the drugs of choice right now that are being presented are alcohol, meth, and actually synthetics. The synthetics, when we talk to our compliance, that's the synthetic cannabinoids and bath salts and other chemicals that you may have heard about. Bottom line is it's an issue of cost. It's easily available on the street and it's very cheap, and so it makes for ease of use for the individuals that are usually coming to us out of homelessness. And when we're talking about homelessness, we're really talking about chronic homelessness. On average, the individuals that come to us have multiple episodes of homelessness, usually 3+ years of homelessness in their experience, often many, many more than that. And they also present with issues around trauma. Now, we need to, when we talk about trauma, we're really talking about doubling up on the trauma experience. Many come to us with adverse childhood experiences, ACE, with their scores would be very, very high. And they have long-term issues that have presented and also were a factor in why they ended up in homelessness. And the reality is that being in homelessness is traumatic in and itself. So what we're dealing with is trauma compounded on top of trauma. We also are wrestling with multiple interactions with the acute care services and law enforcement. For many of us who do outreach in the community, we are often receiving referrals from crisis stabilization units, detox facilities, emergency departments, and jails. And usually when we talk about jails, we're talking about ordinance violations that the individual in homelessness is being picked up on. Many communities have put in play challenging laws that, for example, urinating in public, sleeping in front of a store, sitting in front of businesses and other things like that often are what individuals get picked up for. And it's frustrating. And actually it's been our experience that it's frustrating for law enforcement as well. And then ultimately, if you're wrestling with homelessness and dealing with chronic homelessness and have all the other challenges, we see a pervasive hopelessness experienced. The individuals are truly wrestling with a loss of hope, a surrender to the world around them because they just don't know what they can do to change things. And in fact, because substances are often invariably involved, why get sober? Why do I want to look at sobriety? Now, presenter confession. This is important for me to share with you. I've been in the treatment world, I'm a licensed mental health counselor. I've been in the treatment world for, as you saw, 33+ years. Just over the last 2 years came to the permanent supportive housing side of behavioral health. And in truth, when I look at my own understanding of permanent supportive housing or stable housing in general, I knew it was important, but I didn't really fully understand how important it was. And I'm embarrassed to say that I really didn't get it until I started working on the housing side of things and seeing how just insurmountable finding recovery is without stable housing. And and because of it, even though I'm still developing my understanding of the whole concept, and I'm hoping I'm sure there's many of you on this that have probably a better understanding of the whole continuum than I do. But I really felt compelled to provide this training and others and to speak out about permanent supportive housing, because I think many of us on the treatment side of things, those who are providing the outpatient counseling, MAT services and other things like that, don't fully recognize or acknowledge how we have to use stable housing is part of the treatment continuum. It has to be. And in fact, in my opinion, at this point, I feel like it is the cornerstone for everything else that moves forward. So Bear with me. The Office of Housing and Urban Development definition of permanent supportive housing. Permanent supportive housing is a permanent housing in which housing assistance, examples long-term leasing or rental assistance, and supportive services are provided to assist households with at least one member, adult or child, with a disability in achieving housing. If you notice, I'm coming at this from the HUD's perspective, housing, and this is important. Many of us on the behavioral health side are used to dealing with SAMHSA and the push downward from there to the state level and down to the local level. And what we need to recognize is we're really talking about two federal lines of systems. We are talking about Office of Housing and Urban Development, which deals with rental assistance and other funding supports for housing, while also coupling that with the behavioral health needs as we move forward. And what is supportive housing for? Individuals who, but for housing, cannot access and make effective use of treatment and supportive services in the community, and, but for supportive services, cannot access and maintain stable housing in the community. Now, the reality is, permanent supportive housing, a person's need for housing is no different for many of us. And I think what's uniquely happening right now is, and this is an unfortunate statement, many of our staff, are providers, our partners, heck, our hospitals, our law enforcement are now dealing with struggles with housing themselves, with the rates of increase in rents and housing costs and other things that have just ballooned over the last year or so. So I think we are in a time where many individuals who would not otherwise be wrestling with housing needs are now acutely aware of what their experience is and have a new perspective and understanding of what many of our individuals that we've served wrestle with on a day-to-day basis. All right, Rebecca, I think that at this point you take over and play the video.
That is correct. I will get it up.
All right, I know that was Colorado related, but I thought it was relevant and covered in a pretty succinct way many of the things that we'll be going into more detail on as we go forward with the presentation. So, you can get in contact with Colorado, but I think focusing on us would be great. All right. This is kind of a schematic, the dimensions of permanent supportive housing, and each of these 7 items I'm going to go into in more detail. Let's see. First off, choice in housing. Individual choice is a core element as we look at what we need to do with regard to permanent supportive housing. If individuals are placed in a setting that does not meet their needs and preferences, they are not likely to succeed. Basic choice includes who else lives there, what type of housing is it, where is the housing, and when can they access the housing. I think that over the years we have really fully started to recognize that just saying, well, you've got a bed and here you go, you should be grateful, is not the way to work this. That we need to be sure that when we're looking at placements and assistance with someone finding permanent supportive housing, for example, if they're joining in a housing unit with other individuals, does it look like those individuals all will be able to get along? Do they have similar interests or likes or challenges that maybe they could help be supportive with each other for? Giving them the opportunity to the individual who's joining us for housing to see and tour and maybe see pictures of the housing units that they're going to be entering into. I think that we have to be mindful that the individual needs the opportunity to have some say in where they're moving to. Now, as I say that, I'm going to share a reality. Castle has over 800 beds at this point, and in the next number of years, next couple years, we'll be up close to 2,000. Even with that, right now, we probably have maybe in each of our communities 1 or 2 beds a month that become available. So our ability to provide choice is strained, but we would look at the current housing situation and maybe work with residents to see if they would want to move to other locations to make better mixes in terms of where our residents stay. But it is a challenging situation, and if it's a challenging situation for us, I'm sure it's a challenging situation for those in your community that provide permanent supportive housing. Separation of housing and services. This is real important because of when we're talking about housing, we're talking about landlords, rents, leases, and all those things that many of us deal with on a day-to-day basis in a standard rent lease agreement. And then with this, the idea is to provide case management and other wraparound supports to connect with the individuals participating in the housing. But the key is that it is not required for them to access specific services to be a participant in the housing, and that's part of the Housing First philosophy that I'll get to. But various approaches to implementation of separation of housing and services, the legal separation between housing management and service delivery. Typically that looks like you may be a case management provider for housing supports and work with a series of landlords that that will provide leases to your clients that you're serving. Functional separation, which is actually the model that Castle provides, distinct housing and service staff roles. Our case managers work to help support our residents with setting up their leases and all that, but ultimately our property management side of our organization attends to the lease issues and other things like that. And then there's the model of operational separation. Service providers are based off-site. When scattered housing, you're dealing with that. We actually have models that are on-site and off-site, so both can work very, very well. decent, safe, and affordable housing. The HUD standard of, and you know, I think about this, and I almost hate the word decent. It's out of the standards from HUD with their housing quality standards. You know, I really would rather say, let's look at quality housing. Would, you know, our approach, and I think I implore individuals who provide permanent supportive housing to look at, would you want your loved ones or your family members to live in that housing? And if you're saying not so much, then why do you want to put anybody else in that housing? You know, it's been our experience that when you provide good quality housing that treats the individual with dignity and respect, the individual entering the housing will often aspire to that. If you're putting them in a box and a utilitarian with just a function, and also what's also key in this is not just about the housing itself, but where the housing is located. Are you in a blighted community? Are you segregating off to the side? And I'll get into that in more detail. Where the individuals are residing. Are they in rough neighborhoods? Think about this. We have individuals coming out of homelessness, often with co-occurring disorders. We are placing them in housing in a community or a neighborhood where there is a high crime rate, high substance use rate. And the reason for that is because it's cheap. It's a cheap place to place them. And I think that we have to get beyond that. Because what we're doing is we're putting them at risk, just by the fact that I liken it to, okay, here's the person who's in treatment for alcohol use disorder, and we go and find employment working at a bar. It makes no sense. So we have to look at really bringing them into areas where it is like middle class America. Housing affordability. This is a major challenge, and I'll get into more detail in this as we move forward in other slides with regard to vouchers and other things like that. But tenants pay a reasonable amount of their income toward rent and utilities. And the HUD affordability guidelines are that any of us, doesn't matter those who are coming into PSH, any of us, if we're spending more than 30% of our adjusted income for housing expenses, we are at risk of losing our house. We are financially challenged at that point. I'm going to speak to Sarasota because that's where our offices are based out of, and I'm going to read you some information in terms of income levels based on how many are in the home, and then the rent limits that should be charged to keep someone within that 30% of adjusted income. So, and you can find this if you go online. You can look up HUD's average median income AMI levels, and they post it. Actually, they get to the detail where they'll even go into specific zip codes in your community. You can find those out. But for Sarasota, the Sarasota County, which includes Northport, Sarasota, and the Bradenton area, which is actually in Manatee County, but overall, the 30% income level, if you're a single person and your income is $18,150, your rent for a efficiency, which would be just one open room, would be $453 a month to stay within the 30% guidelines. If you are in a one-bedroom unit, it'd be $486. And it goes all the way up to, if you had a 5-bedroom unit, it would be $829 per month. What we're seeing in our community is rents, and I think this is pretty consistent across the state, with the levels of rents going up by 50% or more. Our average one-bedroom unit in Sarasota County is currently leasing for $2,300. And I think that is in and around that range is what most of us are experiencing in our communities. That's not anywhere close to this 30% that I just shared. So it really poses a challenge. And Many of our residents come to us with their only income is going to be SSI or from SSI, SSDI, and typically what they're looking at is about $800 a month. You do the math. And so it really is incumbent on the case management team to, as the individuals are wrestling with covering their rents, to make sure that they have access to other supports, because how do you eat? How do you pay for food? How do you pay for any of the other bills that you may have that you need to address? Housing integration. Housing in regular residential areas, in terms of like scattered site, mixing populations in buildings or neighborhoods to avoid stigma. Tenants participate in community activities and receive community services, and natural supports are vital and encouraged. What this means is again, I alluded to this in a couple slides previously. We don't want to look at, well, we'll place them over here. We'll cluster them all together, and those people, and I can't tell you how many times I've heard that, putting those people away from regular society. Our model, and we'll go into more details, we do a lot of scattered site housing, where we have housing throughout many neighborhoods throughout Southwest Florida. And they are working class, middle class neighborhoods with quality homes. And many of the individuals that are in the housing, the neighbors may not even know that those individuals are participating in a PSH project. The also key is working to help assist them to integrate into the community, making sure that they know where and how they can access their community supports. And supports are to include, how do I access grocery? How do I access the bank and other things like that? And then being involved with clubhouses and other things that would help them if they're there with a mental health condition, or where I would go and attend meetings. A lot of times when we're talking about is finding opportunities for them to engage in positive situations rather than in looking at just sitting around and twiddling their thumbs as they watch the world go by, and maybe putting them at risk of engaging in other activities that could lead them to lose their housing. Rights of tenancy. This is so important. Having come from the treatment side, it had been my experience that and usually it was in the halfway house model or others similar to that, that there were caveats or prior expectations prior to entering into housing, that the stipulations are, well, you have to be in recovery, you have to be participating in a treatment program, you have to be stable on your medications, and that we often will do month-to-month experiences or situations rather than establishing long-term or full year-long leases. And with permanent supportive housing, we really do need to to establish that the residents have full legal rights in a tenant-landlord relationship. Tenants must abide by normal standards of behavior and conduct outlined in a lease. And the agreement between the tenant and landlord determines length of stay. Tenancy is not contingent on program or treatment participation. And this is where the case managers can really provide assistance. They can help navigate and explain the leases that the individuals may be entering into if they are entering with a landlord that is not part of your programming. But even if they are, leases need to be explained so that they fully are aware of the expectations of the lease itself, but that they do have rights. It can be a challenge. We've had a number of tenants who've entered into our housing that for whatever reason have just made decisions that they were not looking to improve, and in fact have unfortunately taken advantage of the housing to continue destructive behaviors that then also start to disrupt other tenants. So it can be a challenge, and we then have to go through the standard process of eviction if necessary. But usually we're able to mitigate and address those things to prevent that. All right. Access to housing. Access to housing does not require a demonstration of readiness, and you'll hear this over and over again. Research does not show that an individual with mental illnesses does better in housing if they pass a readiness screen. Access to housing should only include those elements required of any tenant, for example, the ability to pay rent. It's important, they may not be fully stable when you're in the process of bringing them into housing. And it may take some time to include accessing crisis management services in the early stages. But it's been our experience in the long term that over time those needs decrease as stability is established. Housing First seeks to eliminate barriers to housing stability. Achieving and sustaining tenancy is the primary goal and focus. Again, as I said in my confession, without stable housing, the rest of it really doesn't work. And so we really have to work. In my experience and my belief at this point is that's where we need to be approaching this from. And privacy of the unit is under the tenant's control. One of the things that our case managers do is, they all will have their own keys. And many times if we have, for example, a 3-bedroom home that 3 individuals are participating in a shared lease with each other, they each will have their own key to their bedroom as necessary and to the housing. And their key is their process to get in. And we don't, we may do housing checks, but it's really about stability checks to make sure that the individual is addressing and hopefully engaging in the services that they need. But it is their choice, and I'll get into that with a Housing First approach. Flexible voluntary services. Tenant preferences are explored at entry through access to a range of services and opportunities to modify service selection. Individuals can accept or refuse treatment or other services, but staff must continue to offer support and use flexible engagement strategies. Essentially, they may refuse, but that doesn't mean we don't keep offering. We keep engagement and stay consistent with our participants. Service options remain available for tenant choice and change as needed or preferred by the tenant. There may be times when you bring someone into a housing property and for whatever reason, the mix of the peer group in the housing may not be working well. And so we'll work with them to determine if they are open to making a change to maybe different roommates or other things like that. But again, it is their choice. It is not a stipulation. And then type and location, intensity, and frequency of services adjust to meet tenants' changing needs. And it really does change. Especially, remember, when we talk about permanent supportive housing, I think many of us on the treatment side would think, okay, 6 months or more. No, we could be talking years. In a couple of our properties, we have individuals who have been with us 10 plus years. And that can be an expectation. Risk management and crisis planning are part of the plan and support and developed in partnership. Often our first and understand, when we start this whole process in terms of creating opportunities to develop a better understanding of the client's needs and work with them to create an individualized service plan, often that is happening as our first contact with the client is homeless outreach taking place on the streets, in camps, under bridges, in temporary motels, shelters, meal sites, libraries, public facilities, and wherever else people might be located. Often needing multiple outreach contacts to establish trust through demonstrating our consistency. Living in homelessness, and I'm grateful I've never had that experience. So what has been shared with me by our residents, when you are sleeping with one eye open and you are often looked at in negative ways by people in the community and are dealing with being rousted by law enforcement and other experiences, it's very hard to trust and to feel like you're that us as or providers and they have long histories of experiencing of the system failing them. They start off with something and then because of an arrest or something that they get excluded from opportunities to stay engaged and involved, and the key is to establish rapport and engagement with them through consistency. You don't have to be the most prolific talker or engager in services. It's really about, are you going to do what you say you're going to do? That is so important. And so as as we do that, we're able to establish a better understanding of what the client's needs are, and work with them to create that individualized service plan and to move them forward. Um, and then a continuation of flexible voluntary services. Services provided are consumer driven and recovery focused. Quality and adequacy of the services are monitored and maintained. Optimized caseload sizes, team-based behavioral services, and 24/7 service provision. That doesn't mean you may be. I'll give you an example. Castle is not a provider of behavioral health clinical services. We do case management, we do supportive housing and living, outreach, and recovery support with our peer specialists. But we are not the clinical provider. Our collaborative partners are so key in the success. But we have to ensure that the client has choice in where they're going, and often require us to help advocate for them to ensure that they're getting the services that they need. And that can evolve over time as we look at recovery as a lifelong experience. All right. Now I'm going to pause here for because this is a pretty long opportunity to see if we have any questions. Rebecca, do we want to just kind of open up the chat for a few questions, and then we will take a 5-minute bio break here because I'll be charging forward with the rest of the presentation.
Sure. If everyone would like to, if you have questions, you can go ahead and start placing them in the chat, and I will help you read them.
I must be doing such a great job. No, that's fine. And I think there would be more questions, especially around tax credits and other things like that as we go on. All right, so let's just go ahead and take a quick pause for if you have 5 minutes. Rebecca, you want to start a timer?
Yes, we will meet back at 10:50. Starting right now, 10:50.
Thank you.
Hi, everyone, and welcome back. I am going to turn this back over to PJ.
Thank you, Rebecca. Couple things. We have a couple things in the chat, and I know Marcy McMath is actually participating via her cell phone and is struggling. And I think many of us, as many of us do, with trying to do chat with WebEx on your phone can be like trying to herd cats at the same time as a hailstorm. So she has requested, I'm not sure we can do this. She has requested to be unmuted so that she could state her question. Is that possible?
Unfortunately, no, that is not possible.
Okay. Hopefully then, Marcy, we'll get to your question that you have, and maybe as we get along at the latter part, because we will have another round of question opportunities. But there is a question in here about, is supportive housing an abstinence program of housing units? Well, I'm going to get ready to answer that question with the next part of this when we get into housing first. I think that's a great segue into the next section of this presentation. So, what is Housing First? Housing First is an evidence-based practice for ending homelessness. It's an approach to servicing individuals experiencing homelessness that prioritize immediate access to safe, permanent, affordable, or supportive housing. It should be supportive housing without the prerequisite or condition of participating in services in order to obtain or retain housing. Client choice is valued in housing selection and supportive service participation. Essentially, it's a harm reduction model. This is contrary to what most of us on the treatment side have experienced in terms of our traditional ways and individuals enter programming. We have often said, well, you got to be sober first before you can enter into the project, the program, the halfway house, or whatever it may be. And that's not what this is. This is come as you are within limits in terms of your stability. And for many, that seems so counterintuitive. But and I would say I was part of that belief for many years. But over the last probably 6 or 7, I've come to understand again, how can you expect someone to get sober on the street before they come into housing? All that's happening in their experiences is they become very clear about how bad their circumstances are and why in the heck would we want to be sober. So, it's really about getting them in and then providing the supports and giving them through utilization of motivational interviewing. Case managers can work with those individuals in that, using that modality, not as treatment providers, but in terms of how they communicate with the residents or potential residents as they enter. What is Housing First? Informed by a harm reduction philosophy. Once in housing, a low demand approach accommodates the individual's alcohol and substance use so that relapse will not result in the individual losing housing. Now, that doesn't mean it's a free-for-all, and I'll get into that later, but it really is about working with them to engage in services first. An individual's housing is engage in housing first. An individual's housing is maintained even in the event of admission into an acute care facility for short periods. Many times Castle has had experience where we bring someone into housing and they have not made the decision to be sober yet. And it may result in us having to provide Martinacs on numerous occasions, but that doesn't mean that their housing is jeopardized. It just means that we're working to help provide stability for them. And keeping them safe, and that's so powerful, so that they know that they have the support to make their choice in moving forward with their recovery. Case managers use evidence-based practices, as I alluded to, for engagement, including motivational interviewing and client-centered counseling. And in many respects, think of it this way: many referrals for our housing, and I'm talking about all permanent supportive housing, generally speaking, are often received through homeless management information systems within your community's continuum of care organization. If what I just said does not make sense to you, you've got some homework to do. Look up who your homeless coalition is. find out who is running your continuum of care, your HMIS system, or however it's called, where they are tracking those who've been identified as homeless through the different partner organizations that bring in outreach and other supports, and partner with them. In many, I think there's 20 counties in the state of Florida that have that participate in Florida's statewide PATH grant, which is Projects for Assistance in Transition from Homelessness, targeting outreach and engagement with individuals with mental health conditions and are homeless. Oftentimes, for those individuals, the two big approaches with PATH are working on trying to bring the individual out of out of homelessness, and also to work on helping them secure their SSI or SSDI through SOAR. And I apologize, I have it on another slide. I cannot, I've dealt with SOAR for years, but I cannot keep it in memory what that acronym stands for. But bottom line is, it's a bird dog approach to helping the individual bring together the information necessary to work with the Social Security office to help that individual secure their benefits that they would likely qualify for. It's challenging for many of us to successfully navigate that. Never mind if you are wrestling with consistent supports for your mental health condition while being homeless. It's almost impossible. And the whole goal is to speed up the whole process of securing SSI, SSDI. And when I say speed up, that still doesn't mean fast. It means better than 2 years, bringing it within hopefully 6 months. And it really does require consistent attention, and it's usually the case manager who's providing that. Many communities have designated homeless outreach teams. Typically, they're connected with law enforcement organizations, usually a law enforcement officer coupled with a case manager or outreach specialists that work in areas where there are high numbers of, or areas where homeless gather, and to work to bring them into supports, or in many communities, I guess I shouldn't be upset for what drives homeless outreach teams, but for many political environments, it's driven by we need to get those folks out of eyesight, and it's unfortunate that NIMBYism in terms of businesses and otherwise that look at it from that perspective. But they often, with the homeless outreach teams, will have access to transitional housing supports through shelters and other things like that. And they work very closely. I know with us, we work very closely with the homeless outreach teams in each of our communities that have one. In fact, we have regular meetings as we look at trying to coordinate with each other for individuals that we're trying to bring out of homelessness. All right, principles of housing first. Principle 1, immediate access to housing with no housing readiness conditions. It is get them off the street and into housing as rapidly as possible. It may be a transition. It may mean that they would enter first an acute care facility, oftentimes detox. It can be the crisis unit, but it has been our experience more often than not, it is a detox facility first. And then from there, once they've stabilized enough to where they're able to be cognizant of signing leases and other things like that, because we do need to ensure that that does take place. Consumer choice and self-determination. Just because we're making the offer for housing does not mean that they will accept today. It may take time. It may take, as you saw in that little cartoon video clip, I can't tell you how many of our individuals that we've tried to bring into housing struggle because they have a pet, usually a dog, almost invariably a dog that they do not want to separate from. That has been that is their anchor to the world. I mean, many of us have pets that we would not, we may get rid of our spouses before we get rid of our pets. And we need to be mindful that that too is the situation for many who come in. in trying to determine if we can allow that within reason to move forward. Consumer choice, recovery orientation. The idea is to work at them pacing and identifying how they're going to move forward with their recovery. It is our goal is that it's a lifelong experience. This is not, again, coming from the treatment side, one of the most frustrating things that happens, we are dealing with chronic illnesses that are lifelong and can be treated but cannot be cured. And systems are set up in many respects to be time limited. I think it's important for us, especially on the substance abuse side, and I think it's heading in that direction with medication assisted therapies and other things like that, to recognize that we may need to provide treatment supports throughout the lifespan, but we really do need to work from a recovery approach. Individualized and client-driven supports, again, that they have choice in how they want to move forward, which may mean, again, as was stated earlier, I don't want to go to participate in counseling or other services. Okay, well, let's continue talking about it, but it's not a requirement. We'll just keep exploring it as we work together. And social and community integration. Looking for many of our residents, the vast majority will not be entering the world of work. Some do. Some work part-time. Many, especially if they're on benefits, they're limited by SSI or SSDI. They're limited by how much they can work and what income they can make before they put their benefits at risk. Many individuals do not have the idea of work is not reasonable. And so what other things can they do to be productive and feel engaged in the community, whether it be participating in clubhouses, drop-in centers, maybe some volunteer work. In several of our communities, like the one you see behind me here, Arbor Village, there's individuals on each of the floors that often will cook for everybody else on the floor, because that's what they're doing to help give back. That it gives them value, and it's remarkable and wonderful. Housing first. Housing first approach rests on two central premises. The best way to end homelessness is to help individuals move into permanent housing as quickly as possible. And once in housing, formerly homeless individuals may require some level of services to help them stabilize, linked to long-term supports and prevent reoccurrence. It's really about recognizing that you have to have both, but the client, the resident, they need the opportunity to have choice in how that works. It's recognized as a dramatic response to the problem of homelessness. The housing first approach rests on the two central premises, as stated here. And housing first approaches have been adopted for a variety of target populations successfully. Housing first programs, whether for families or chronically homeless adults with psychiatric disabilities, generally focus on helping their target populations to move as quickly as possible into permanent supportive housing of varying types, and then provide them with voluntary home-based support services, either time-limited or long-term. And it's been our experience that it's sporadic, but generally it ends up being long-term, especially if you are in a position to provide any level of transportation. Because in Florida, public transportation, and here's a real sophisticated term, sucks. I don't know of any community that has adequate public transportation. Maybe Hillsborough, Tampa, Miami, in certain areas, but generally speaking, the big barrier to accessing services and supports often is transportation. Defining housing first philosophies. And I know some of this may seem redundant and repetitive because it is. The intent is to continuously revisit this as part of this presentation so that when you walk away, that it's stuck in your brain, I hope, and that you will take it to heart and hopefully put it in place where you're working. Defining housing first philosophy. Safe, affordable housing is a right and prerequisite for effective services. Provide permanent housing opportunities as soon as possible. Do not focus on housing readiness or sobriety as a prerequisite, and facilitate easy access to housing. Housing stability is the primary objective. Incremental change is normal, and quality of life and well-being measure success. All right, time-wise. All right, so I need to move on. Core services of Housing First. Crisis intervention, often that is, as we deal with outreach in the community and bringing them into engagement, crisis intervention, whether it be utilizing acute care services, often that's the case, are what help to stabilize the individual so that they're able to move in towards permanent housing. Permanent supportive housing. And again, it's about stability. Are they capable of managing coming into housing, or are they in a situation where their crisis is that out of control that they could jeopardize and harm themselves or others in their circumstances? We need to provide that ability to provide stability. Permanent housing services helps participants obtain permanent housing, case management and wraparound services, and recovery support, which I'll go into more detail. We have, over the last year, Castle has started to utilize recovery peer specialists in working with our residents, and it is proving to be one of those V8 moments. Having worked on the treatment side with recovery peers going into hospital settings, emergency rooms and otherwise, working in this environment makes so much sense. And I've been using the word recovery, so I'm going to define I'm going to share with you SAMHSA's working definition of recovery. Recovery is a process of change through which people improve their health and wellness, live a self-directed life, and strive to reach their full potential. There are four major dimensions that support a life in recovery: health, home, purpose, and community. And health is defined as overcoming or managing one's diseases or symptoms and making informed, healthy choices that support physical and emotional well-being. Here's what's very important. What we find as we bring people out of homelessness is they often present to us with chronic health conditions as a consequence of being homeless, and maybe ongoing heavy substance use and or untreated mental health condition that have brought about consequences. And in fact, in this property behind me here, we opened it on March 18th of 2020. Woo, right in the middle of COVID. 80 units in that apartment. Of those, 71 individuals entered were homeless. And during the first year, 5 of those individuals passed away while in our housing, 4 of which came to housing and ended up moving to hospice. And the reality is that they came to us for hospice. Their health issues were so severe that they entered housing knowing we knew after bringing them in that they were going to pass at some point. But I say this: where do we want that to happen? Do we want that to be on the street or in the comfort of their own place of residence, that they have the dignity and respect to be able to have a place that they can be safe as they're dealing with the end-of-life experiences that they were dealing with? But health issues are often as time goes on, as you are maintaining individuals and supporting them in permanent supportive housing, often we transition from they've been often able to stabilize their behavioral health conditions and other things such as that, but their healthcare then starts to become the prominent issue that we need to address. And working to help support them get access to adequate healthcare is key. If any of you know about federally qualified health centers, I would look for those in your communities. Those are a godsend in our communities and others that we work with to provide access to care, because if your resident does not have insurance, their struggles to find indigent care can be almost insurmountable. And FQHCs are a wonderful resource. Also, using a trauma-informed approach. A program, organization, or system that is trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. Many of us who come into the behavioral health field did not enter because we thought, wow, this is just a great way. I'm going to go make me a good living working in the field of behavioral health. It just looks interesting to me. The reality is most of us come to this because of our own experiences that have affected our choices around working in behavioral health. As a part of self-disclosure, I came out of a household. I had a police officer and a nurse for parents, both of which entered sobriety when I was 12. Many of us have those type of experience. I would not be here if it wasn't for that. I started college to be an architect and found my path. I was better at telling you about math, how you feel about math, than doing it. So I made a career change. But I guess now I get to scratch two things because I'm actually involved with developing properties that are in support of behavioral health needs. But when we're looking at this, many times the trauma is not adequately addressed for us as members of the staff, and being mindful of, especially on the treatment side, but all sides. I don't want to focus on one area, but it's also about who's at your front desk and how do they work with and engage with your client. What do they bring to the table that could affect how they view the individual who's presenting for services? Could be your folks, if you have them in a residential center, your cooks, anybody, your techs. What are we doing to recognize everybody's need to address trauma? And remember, as I mentioned early on, when we looked at the profile of the participants in this, their trauma is very often compounded by what they experienced in their childhood and as they grew up, and then also being homeless in it itself is traumatizing. The foundational principles of trauma-informed care are safety. Patients and staff feel physically and psychologically safe. Trustworthiness and transparency. Decisions are made with transparency and with the goal of building and maintaining trust with the participant. Peer support. Individuals with shared experiences are integrated into the organization and viewed as integral to service delivery. Collaboration and power differences between staff and clients and among organizational staff are leveled to support shared decision making. And empowerment. Patient and staff strengths are recognized, built on, and validated. This includes a belief in resilience and the ability to heal from trauma. And finally, humility and responsiveness. Biases and stereotypes, examples based on race, ethnicity, sexual orientation, age, geography, and historical trauma are recognized and addressed. Some of the consistent findings in research related to housing and services making a difference. More than 80% of supportive housing tenants are able to maintain housing for at least 12 months. In this property, we reached in March our 2-year period, and we've had a 92% retention rate, meaning 92% of the tenants remained in the housing and were not evicted over a 2-year span. Even in general apartment complexes, that's remarkable. I'm very proud of that number. I think it's remarkable, but and I'm not expecting it to continue in all phases of our housing, but it really does, if it does anything, it reflects how stable housing with supports can keep someone placed. Most supportive housing tenants engage in services. We often will experience that our participants will initially not engage or have limited engagement in services, but as they watch their peers improve and other things like that, they often will make the decision over time to increase their level of engagement and utilization of the supports that we can provide. There is a decline in usage of most costly services, the acute care service system. Um, uh, in our community, we looked at, and when I say our community in Sarasota County, we looked at the average cost of an ER, an emergency department visit, is about $2,000. That's the emergency department. Now, if they end up on the other floors, the costs go up exponentially. Also, that's about the average cost of an individual who's arrested and placed in jail. Detox admissions typically on the average cost of between $700 and $900, depending on your community. CSU admissions typically around $1,200. Those are very expensive services. I know many of our communities are addressing high need high utilizers, those that are frequent users. Typically what that means is an individual who over the last 180 days has had 3 or more admissions to an acute care setting, CSU detox, or has had a placement for 16 or more days in a detox, or has been assessed in a detox or CSU, and or has been assessed. They may not have been admitted 3 or more times during that 180-day period. Let's see. Nearly any combination of housing and services are more effective than services alone. Okay. Sustaining housing first. Biggest challenge is locating enough affordable housing to meet the tenant demand. There is such a challenge with housing available in general right now, and I'm not going to go in and belabor it, but just know that it is at a crisis level across the state of Florida and the nation. But it is a major challenge for many communities. I know for our community, our hospital is losing potential. Sarasota Memorial Hospital can't hire employees because they can't find any place that they can afford to live. So it's just a reflection on what we're wrestling with. Require at least one or probably several of the other housing subsidies. Many, again, as I referenced, leasing challenges, and I'll go into this when we get into what the vouchers look like. Working with your organization, usually your housing authorities are the organization that manage your vouchers. In some communities, it's through your COCs or others like that, but working to try to identify and secure vouchers for the individuals that you're working with. Often, the struggles can be that they present with maybe a felony history or evictions. That could be a challenge as well. Developing strong relationships with landlords, that is so important. If you are not the housing provider and trying to identify housing, you really have to have your case management team work closely and establish relationships with landlords. Because a lot of times you're asking them to take in individuals that on the surface they look like risky individuals to lease with. But the key is that they also come with the support of a case manager that can help mitigate the challenges that could be trouble. Focus on increasing tenant incomes. That's a pie in the sky in many ways. Many of our residents, again, as I said, probably less than 10% actually have some level of employment and they rely on their Social Security for their primary source of income. Developing new affordable housing that is financed in such a way, and I'll get into that. I'm just going to go ahead and move on because of time. And then again, the harm reduction approach. I used to be one of the old guard, abstinence-based. I thought that abstinence only was the only way to go. And I've had to mature my thinking to recognize that, we do need to give individuals the opportunity to address it from what they feel like is important and start off with that, though it's not an anything goes, but that they aren't necessarily expected to be sober first to engage in services. Key ideas to keep in mind. The goal of all of us is to help individuals succeed in housing, regardless of their sobriety or use of substances. The quality of life of individuals with a substance use disorder can be improved and enhanced while they still use drugs or alcohol. Individuals can have a substance use disorder and still function and meet life obligations. Tenants have both rights and responsibilities under their leases, and the lease will guide our response to their issues and behaviors. In helping individuals reduce the harm caused by their substance use, self-awareness is increased and other benefits follow. Again, harm reduction principles. Individuals have the right to make decisions about their lives and actions. Harm reduction is about educating them to make the best decisions for themselves. And it's important that we actively communicate. And if we develop a trust with our residents over time, it's been our experience that I begin to you think about the readiness for change. The stages of change: pre-contemplative, F you, I'm not doing it. Going from there to contemplation and preparation, then action, and then maintenance. And I think that there's the importance of recognizing that depending on where they are, we need to help them move along while rolling with their resistance. And yes, there's someone put in the chat. I think Rebecca will be putting I'm like squirrel. I see things as squirrel. The presentation will be in PDF format, and I think she's already put it at the beginning or at the end will be put in the chat as a link. All right. Now, symptoms and behaviors of housing issues, and this is important. This is the things that would jeopardize someone's lease that go for anybody. Illegal activity leads to lease violations. There are times when we may have a resident that has made a decision that they're going to actively use substances that are illegal, and they put their other co-renters and their roommates or housemates in jeopardy, and we have to look at those kinds of things, just as would happen with any other leasing situation. House rule violations lead to complaints and nuisance issues. Poor money management leads to rent non-payment. Poor hygiene or hoarding leads to failed inspections. We probably on average deal with probably one or two clients a month with issues around hoarding. Hygiene, yes, but hoarding for many is. I think many of our residents come out of homelessness, and they now have a place to put things and save, and often it becomes a scramble to gather as much as they can to keep they now have a place to put everything that they want to maintain. Excuse me, sorry. Property damage leads to failed inspections as well, and unauthorized subtenants lead to lease violations. In the property behind us, when we opened it, we had many of our residents who just literally started allowing others that were not tenants coming into their housing because they shared with us that they felt guilty for being able to have such a nice place, and often were taken advantage of by those who were still out on the street, and we had to deal with individuals who were staying in the housing that were not tenants, and because oftentimes those individuals were the disruptors and causing challenges, not just with the individual that they were taking advantage of, but also other tenants in and around them. Housing first is not an anything goes approach. Again, supportive housing, it works. Studies across the U.S. show that 75 to 85% of single adults and 80 to 90% of families stay housed in supportive housing. This includes hard to serve populations with very high needs. Formerly homeless people, especially people with highest needs, are more likely to stay housed when they are in programs with voluntary services and other client-centered practices. Appreciate your patience as I click through two different screens. Supportive housing. A study of chronically ill homeless individuals found that housing led to a 29% decrease in hospitalizations, a 29% decrease in hospital days, and a 24% decrease in emergency room visits. The cost of services for people housed in a Housing First program declined by 53%, or roughly $15,000, in their first year after housing. In other words, every $10 invested in Housing First programs leads to an average savings of $21.72. The scope of services often involved with permanent supportive housing includes outreach, which can be homeless outreach into the community or into areas where homeless gather to receive services. Case management, supportive housing services. That's often, we do a lot of transportation to and from appointments. Peer support with recovery peer specialists, and I'll get into that in the next slide. Transportation is key. Working with SOAR, there it is, SSI outreach and access to recovery. I knew I had it on the slide. Collaborative partners, I can't begin to tell you how important our collaborative partners. We have over 75 different organizations that we work with on a daily basis throughout the communities we serve. And we would not, our housing would fail without our collaborative partners from, just to name a few, Centerstone, Tri-County Human Services and Polk, First Step, Salus Care, David Lawrence Center, Charlotte Behavioral Health, and all the All Face Food Bank. We are a food pantry because many of our residents struggle with food inequities and just don't have access to those needed food services and supports. Advocacy. Oftentimes our case managers will attend different meetings and appointments with our clients because they are so anxious and nervous about different things that they're afraid that they're going to miss something. And we often will be there to help them take notes as necessary or to advocate on their behalf when they may be afraid to advocate for themselves. And then acute care system relationships. Working with your CSUs and detoxes and your law enforcement organizations, establishing relationships with them so that you can partner with them rather than work adversarially with them. Peer support key activities, provide support and advocacy. Individuals with lived experiences, it's funny, I've been around a long dang time. I started in the field in the late 80s. And back then, and it was mostly in addictions. When I first started in the field, about 60% of the folks providing services were in recovery. And over time, that titrated down, much driven because they were pushed out of the field because of expected more and more professional degrees and other things like that. And then coupled with the increased requirements around background screening, many of them had arrest histories that precluded their ability to work. And now what's happened is we've come back and took those folks that were individuals with lived experiences providing supports, and we pushed them out, and now we're bringing them back in as recovery peer specialists. And it's so key that individuals can work with those supports, that when you're able to say, do you know what I mean? And they say, yeah, I do, and they do. And they can coach and support to access services. It's not treatment, it's the how-to. It's the holding hands shoulder to shoulder and saying, hey, let me show you how I did it, and let me share with you what my experiences were, and let me introduce you to others that are similar to me in experience and can share with you, whether it be through recovery programming such as AANA, mental health support groups such as NAMI and other organizations like that. and work to, really be a role model, but also help facilitate positive change. Also, and a lot of this was driven out of desperation when COVID hit. Um, you know, case management and supportive services and outreach can be pretty low tech, but really what we've actually taken on is a high tech, high touch approach, and are really moving in that direction. When the whole issue around moving to telehealth hit, many of our clients did not have access to telehealth services. They have a smartphone, but they struggled to be able to connect, and so we had to equip our staff with touchscreen laptops so they could go in and provide that connection for telehealth services. And also, we also would bring concurrently tablets out into the field so that we can work on that electronic documentation while working with our clients. And MiFis are so key to making sure you can access the internet, because most of us aren't working from paper, though that may be how we start in the field, but we're working from electronic medical records and other things like that. The Behavioral Health Index, that's through Inflection. I'm just sharing with you, that's an assessment tool based on the Addiction Severity Index that's web-based that we use, that helps create a narrative. It doesn't diagnose, but it gives you in multiple domains the information you need to be able to provide the supports to establish maybe a provisional diagnosis. It also is based off of motivational interviewing, so there's readiness to change and recognition of the level of severity of the issues that they feel is important is key. It's also, because it's a tool, it doesn't matter who's providing it, it stays consistent across the service continuum, and we feel like it's a tool that we've found very useful. Also, recently, and again, as you saw in my disclosure, I'm the Senior Behavioral Health Advisor for Trust But Verify. Back at when I was at First Step prior to coming to Castle, we were a beta testing site. It's a technology app that works to support our recovery peer specialists and our case managers with helping individuals identify and find recovery support meetings, whether it be AA, NA, Smart Recovery, the full continuum. It gives them the locations, geolocations, and time and start times, and they can use their smartphones, because most of our residents, no matter what, all have smartphones by and large. Now, they may lose it and have to get another one, but they do have them. And so we're able to really work to expand the reach of the recovery peer specialists by helping ensure those individuals are engaging in 12-step or other recovery support groups, and we can verify that that is actually happening using geofencing and other biometrics. And then we're gearing up to, and I think FADAA has, and FBHA has started looking at this. We're moving towards what we would call, and this is not our term, it's coined from Green Space Mental Health, measurement-based care. It's a digital platform that will push out to our residents screening tools such as the PHQ-9 or other anxiety tools or other substance use tools that will on a regular basis push out to the individual to their email or to their smartphones, so that they can complete, through texting, can complete regular ongoing screenings separate from when we come out and visit. And it will help us in real time track how they're doing, how they're improving or not, and also give us an aggregate ability to see how our overall objective measures are doing in terms of behavioral health. I think we have, in this field, we don't do a really good job of demonstrating our effectiveness, because it's very hard to get to anything objective. And I think this moves in that direction. Our goal is for us to go live with it in October. And then housing model examples. Castle, we're fairly large permanent supportive housing provider. We use a lot of scattered site housing. We have about 110 homes throughout 4 counties in Florida, which are from, starting in Alachua. You'll see on a short thing, but bottom line is we have a number of scattered site housing in the community. Clustered housing, we have a couple areas where we have houses in groups on cul-de-sacs. Garden style apartments, that's what this is back here. The village model, we have a little bit of that. Hybrid group home housing And then we also have, we started with Renaissance Manor is our assisted living facility with a limited mental health license. It's a 50-bed facility, and we have some of our tenants we have one tenant that's been there 20 years, which is pretty remarkable. All right, as I said, I should say, Castle will be serving 11 counties in Florida, and you'll see that in the next series of slides. And these are actual pictures of many of our residents, and please understand, this for them, for many of them, this is their forever home, and we need to recognize that if we can provide a safe, comfortable, inviting, and engaging place for them to live, I think that's what we all want, and they deserve it as much as anybody. And our housing models. Renaissance Manor, here's is our assisted living facility in Sarasota, 50 beds. It's actually a primary building with a cottage attached to it, and then a house down the street. Again, we provide 24-hour support, primarily through our techs and our case management staff on site. And then here's examples of our neighborhood housing. We really do work to ensure that the housing is good quality, is maintained well. We have a whole maintenance team that goes out and deals with our properties and addresses any of the maintenance issues. And then we also have a group of outside organizations that we contract with when it becomes a big issue, such as a roof and other things like that. Again, here's Arbor Village in Sarasota. This was our first foray into our partnership with Blue Sky Communities. This is the Blue Sky's a for-profit affordable housing developer, and we partnered together to develop this project. It was a labor of love for our CEO, Scott Eller. He had to fight a lot of NIMBYism to get this established, but once this was in the ground, it became clear that we hit on something unique. We had lightning in a bottle, and this is the approach that we're using moving forward. All right, Rebecca, go ahead. You can play the video. What you're about to see is the virtual grand opening for this property back in March of 2020. But I just wanted to give you a chance to get a feel for the property internally as well. All right. Thank you, Rebecca. And now this was just opened in October of 2021. This is in Fort Myers, Cypress Village. This is a hybrid model because half of the residents are coming. They were coming out of homelessness. It's 95 units, 1 and 2 bedroom units. They were coming into permanent supportive housing, where the other half of the residents are coming out in affordability. So affordable housing. So we have a nice mix in terms of the tenants here. Fairlawn Village, you see, I'm so frustrated. It says 822. This is in Orlando on Mercy Road. It's 116 units, 1, 2, and 3 bedroom units. We'll be opening, actually, we're targeting October. And we're working with our local COC for lease ups to include vouchers for our residents. Swan Lake Village will be opening in Lakeland, actually about in October as well. If any of you are dealing with construction delays and challenges have been the bane of our existence with these developments, and price increases and other things like that as well. Jacaranda Place in Port Charlotte actually is going to be opening, we're looking at the latter part of October. It unfortunately has sped up and they've done a great job. And again, this is going to be 84 units. And then this is a rendering for Miami-Dade. We anticipate, it says 1224, probably 2025, but this will be in the Miami-Dade area, Alto Tower. I believe it's 70 units. And then we have another project slated for Sarasota. And this is important because we were able to secure the property. I would say work with your county governments as you're looking to identify affordable housing. They have surplus properties. See if you can identify surplus properties that could be used to leverage for access to state Florida Housing Finance Corporation tax credit funding that I'll talk about in a minute. We also, many communities are looking at the ARPA funds that they received to help support creating affordable housing, and Sarasota County is not any different. Sarasota County, along with us being able to get the housing, the property in place, have also committed $4.2 million in ARPA funds to help us with the match requirements for tax credit funding. Tax credit funding. All right, let me go into this real quick. And I apologize that this is going slower, or it's, I guess I'm just too much of a chatty Cathy. Bear with me. The Florida Housing Finance Corporation offers opportunities for developers to secure funding support for affordable housing with long-term commitments. Typically, it could be 15 to 30 years. Usually, for us, we've been committing 50 years of affordability for housing opportunities. The Housing Credit Program provides for-profit and nonprofit organizations with a dollar-for-dollar reduction in federal tax liability in exchange for providing equity financing for the rehabilitation with or without acquisition or new construction of low or very low income rental housing units. A housing credit allocation to a development can be used for 10 consecutive years once the development is placed in service and is designed to subsidize either 30%, or which is the 4% tax credit, or 70%, the 9% tax credit of low-income units costs in development. Qualifying buildings include garden, high-rise townhouses, duplexes, quads, or mid-rise with an elevator. I'm not going to go into any further detail, but bottom line is this. Find a affordable housing developer or go to the Florida Housing Finance Corporation. They're very competitive. The 4%, if you can get enough match at the local level, I would recommend you look for 4% tax credits because it's not a competitive process. You can apply at any time. The 9%, you get a lot more. You don't have to have the match requirements, but it is very competitive. And many of, I'm sure your organizations have been approached to be participants with organizations such as Blue Sky, Car4, and others. Ability in the Orlando and Northeast Florida area, and many others. I apologize, I'm missing, I'm sure, a ton of them. And then also looking, as I said, looking for land donations from your county government or city government. and get them to help out with providing local match. This is a prime time to talk to them about it because of the opportunity to utilize ARPA funds. I know Sarasota, St. Pete, Lee County, and several others are committing a good portion of their ARPA dollars, and or cities also got allocations that can go towards helping out with affordable housing. And private donors and investors. We're beginning to explore that. We have several foundations in our community that have stepped up to be involved in looking at how to help support development of affordable housing. And then rental assistance. As I said, there are two types of rental assistance: tenant-based rental assistance, which is someone receives a voucher and it goes with them no matter where they go. And then there's project-based, which are vouchers committed to, we have in Lee County a project-based vouchers that are attached to the scattered housing that we provide. So to ensure that those individuals are able to access it doesn't leave, it stays with the housing itself. Housing Choice Vouchers. The Housing Choice Voucher Program is the federal government's major program for assisting very low-income families, the elderly, and the disabled to afford decent, safe, and sanitary housing in the private market. Since housing assistance is provided on behalf of the family or individual, participants are able to find their own housing, including single-family homes, townhome houses, and apartments. Now, it goes with them. Here's the important thing to think about. And we really work really hard to avoid evictions if at all possible. If you have a voucher and then you get evicted, you've lost your voucher and you will not qualify for any going forward. So you have to really, we will actually let leases expire. That's our preference if necessary, so that the person does not get that mark, even though they may be disruptive with us because of their behaviors. We do recognize we don't want them to risk losing their vouchers. Mainstream vouchers. Mainstream vouchers are tenant-based vouchers that serve households that include a non-elderly person with a disability. Usually, and again, look to your housing authorities for those supports. In some communities, the COC becomes the provider of those. And then there's VASH vouchers, which are targeted towards veterans. Again, similar to Housing Choice vouchers. They are Housing Choice vouchers with the addition of case management and clinical services connected for veterans. And right now, the last I checked, I believe there's enough vouchers for veterans that they would all individuals who are homeless that are veterans could be covered for housing. And then there's most recently through the ARPA funds, emergency housing vouchers. Targeted at individuals who are homeless or at risk of homelessness, fleeing or attempting to flee domestic violence, dating violence, sexual assault, stalking, or human trafficking. And these actually have to go through your local continuum of care. The referrals have to come through them. Traditionally, it's usually directly with your housing authority. But these are a new development, and they're given out in allotments. I would look to pursue those for many of the individuals that are homeless. Many communities have struggled to utilize their vouchers because they just don't have any slots. So the projects that we're developing in the communities that are getting ready to open up in Charlotte, Orange, and Polk counties will likely be filled very rapidly because of there just aren't any other options. Let's see here. And then rapid rehousing vouchers. These are targeted at folks that are just recently entering homelessness. Many folks are dealing with that right now. And these are folks that are pretty high functioning, and it's just the idea of maybe 1 up to 2 years of rental assistance provided, with the understanding that they are likely going to be able to successfully move to providing and supporting themselves in their housing. And we have reached the point in time with the last few minutes for questions. And I will do my best to answer them.
There are quite a few questions, PJ. I'm going to go ahead and read some, if that's okay with you.
Go right ahead, please.
Okay, let me make sure I'm reading it from a third person and reading it back. So let me make sure I'm giving the right information or reading it properly. So Laura asks, for people who currently live in other counties, will they take applications from the homeless or from people who are looking for low-income housing or may not currently be in LIC?
It's been my experience that the vouchers and or if I'm understanding the question, bear with me, I'm trying to read it as well. More often than not, it tends to be county specific. Housing authorities serve their geographic areas, their county areas, with their vouchers, and homeless coalitions serve their identified, like in Lee County. The homeless coalition is through Lee County Human and Veteran Services, the COC, excuse me. And they only specifically serve Lee County, whereas in Sarasota and Manatee, it's served by the Suncoast Partnership. It's often driven as county specific. I hope that answered the question.
Another person asked if you have a list of the housing, sorry, let me see if you have a list of Housing First programs.
The Housing First programs, my recommendation would be to work with go on and contact your homeless coalition that serves your community, and or your COC. Usually they're one and the same, and ask them for who those contacts are. I'll be frank with you, there aren't a ton of providers of permanent supportive housing with a housing first approach. More often than not, what I see is it tends to be more transitional housing in the form of halfway houses and other mechanisms like that have those stipulations of expectation of being in recovery or engaged in services prior to entry. Again, this is where your opportunity to take advantage of what you've learned today and use it as a mechanism to begin the dialogue in your community to pursue opportunities like this.
And then I know you kind of touched on this already, PJ, because I heard you talk about it, but Marcy's question has come up and I just wanted to present it, and I've already spoken on it, but it was about just she works for a housing coalition as well. And she is trying to, one of their biggest challenges is people in active substance abuse and the related behaviors that can come with that. And what do y'all do to kind of combat that? And I know you already touched on it a little bit, but if you could just reiterate it one more time for us all.
I think depending on the level of acuity of the behaviors, meaning that if they're out of control and jeopardizing and putting themselves or others in danger because of their substance abuse or untreated mental health condition, you take advantage of the acute care services while recognizing that's not a exclusionary criteria for someone to come into housing. Utilize and I say that recognizing that not all communities, especially small or rural communities that may not have those types of supports that they need. I wish they did, but it can be a real challenge. But really utilizing the services to work towards stability. It may take, again, it's about relationships. It's about making consistent connection with the individuals so that they can establish a trust in the supports that you're offering. It's not, it takes some patience in many incidences, but it really is about just getting them stable enough to be able to enter the housing without putting themselves or others in the housing in danger.
One more question before we wrap up for you is, do you know how often mainstream vouchers become available?
It's like finding a needle in a haystack in many respects. There are extensive wait lists for most. That's why the EHV vouchers that came out through the COCs are like gold, because more often than not, the mainstream vouchers are spoken for years to come, and someone can go on a wait list and apply. And often, most of the housing authorities will open up a window of application for maybe a few weeks, and the slots all not any new slots available get filled, and then they establish a wait list. And unfortunately, and this is where our advocacy statewide and otherwise, and at the federal level, needs to come into place, is that we are dealing with a situation where there just is not enough vouchers available to support the individuals who have needs. Well, again, Rebecca, I don't think there's anything else. We're right at the witching hour. Again, thank you for the opportunity to present to you today. It's an honor, but it's a calling. I think that my hope is that if you take away anything from this presentation, that it will help you go, you know what, we need to look at this for our community, and really begin advocacy to support permanent supportive housing as a recovery tool that our individuals who are coming out of homelessness and or dealing with mental health conditions desperately need and deserve. So again, thank you for your time today, and I hope you found this a benefit. And I enjoyed the presentation. I enjoyed sharing, and I wish you all well.
Thank you so much, PJ. I don't know if you can see in the chat, but you're getting very high praises, and people said it was just great and very easy to follow. And you got another comment that you're very personable. So I feel like I should share that with you. You're very
Thank you.
personable. So thank you very much for providing everyone with this great information. And I have a couple of items of business to note before we all conclude today's webinar. Please see the chat panel for a link to today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FADAA's website. If you want to receive CEs or a statement of credit, you must complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must have provided an accurate Florida Department of Health license prefix when you registered for this webinar. After you register or sign in, you will be directed onward to the evaluation. You must use the same email address you used when you registered for our website and when you set up your FADAA profile. This is the only way to connect your attendance. You will get a second opportunity to complete the evaluation through a follow-up email later today. The evaluation will close on Tuesday, July 26th. Please remember that. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. Thank you again all for participating in today's webinar. We'd like to recognize and especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. And have a great rest of your day. And remember, the evaluation will close Tuesday, July 26th. Thank you all. Hope you have a great day.
Thanks, everybody. Take care.